Hey guys, welcome back to Clinical Physio. Today we've got another brilliant opportunity to speak to a top-level orthopaedic knee consultant, and today's topic is going to be clinical reasoning for traumatic injuries of the knee. We're going to be diving into ACL injuries, meniscal injuries, and loads of other brilliant clinical gems. You don't want to miss this one. So let's get into it. Let's get clinical. So today's guest is Mr. Trikha, a consultant orthopaedic surgeon and knee specialist operating in the UK. His areas of special interest include surgical treatment and management of knee problems in adults and adolescents, knee sports injuries including complex cases, early and advanced knee arthritis, ACL reconstruction, joint preservation, full and partial knee joint replacement, meniscal and cartilage injuries and repair, patellofemoral dislocation and instability. He operates in several locations, including the Surrey Orthopaedic Clinic and the Shern Clinic in central London, and he and us would like to thank the Shern Clinic for their help in filming today's video. So, without further ado, let's dive in. We are now looking at the rationale and the management of the injured and torn knee, and I know you said that there are 5 main situations that you want physiotherapists and other clinicians to think about when it comes to the injured and torn knee.
Yeah, absolutely. So if someone has an injury on the knee and they have acute swelling, that acute swelling more often than not is blood, and we call that hemarthrosis. Okay, and what you want to rule out is, number one, the most important thing is a fracture or extensor mechanism injury. And a good test for that is a straight leg raise to exclude damage to the patella tendon, the patella itself, or the quads tendon combined, known as the extensor mechanism. And the second one is a fracture to any part of the knee, often tibial plateau or the extensor mechanism as discussed. Okay, and walking, palpable tenderness, straight leg raise, they're the things you want to do. So number one, fracture or extensor mechanism. Number two, major ligament, normally the ACL. Non-contact twisting injury on a pitch, acute swelling, unable to continue, ACL. Number three, a big meniscal tear, a locked knee, a big bucket handle tear, traumatic, got drunk, twisted, pothole on the curb, normal kind of thing. Number four, patellofemoral dislocation, which we've covered. And number five, a little bit left of centre, is someone who's on blood thinners. So warfarin, these new oral anticoagulants, a minor trauma to the knee swelled up, and it might be their blood, they've taken too much, or their INR's too high. And normally, all those five will, one way or another, end up going for an acute opinion. A&E or their walk-in centre for an X-ray to exclude fracture, and then either referral to an acute knee clinic, if there is such a thing, or a fracture clinic if there isn't, for further investigation. So think extensor mechanism or fracture, major ligament, major meniscus, patellofemoral dislocation, and people with blood thinners.
Super. So the big, injured, really swollen knee, those are your 5 things. Fantastic. Love it. So if we could then move on to some of those different pathologies, let's start with the meniscal injuries. And we know that there's lots of different meniscal injuries that individuals can have, and we're talking about with trauma here. What are the main meniscal injuries that you want to know about as a surgeon?
Okay, so when you have the way I treat meniscal injuries are traumatic or degenerate. Traumatic is the injured knee, as we discussed, where 1 minute earlier they had no issues with the knee, and now they've got a big meniscal tear. Traumatic meniscal tears that cause bleeding, by definition, have a blood supply, which means they may be amenable to repair. And by that means we need a repair earlier on later. So big bucket handle tears, you want to repair the meniscus. We know that losing the meniscus causes arthritis. So is it traumatic? Is it a sizable meniscal lesion? Would you consider repairing the meniscus? So relatively urgent repair, never urgent to do a meniscectomy. So if you're thinking meniscectomy, think non-operative, rehab first, think settle down.
Nice.
If you think traumatic, repair, you don't want to sit on that patient too much. If they've injured their knee, they're 20, they've got a meniscal tear, should he be repairing it? Should the surgeon be repairing this meniscus? If that was my meniscus, would I want that healing? Would I need that meniscus? So that's in the acute situation, big bucket handle tears. And what a bucket handle tear is, like a bucket handle, the meniscus, this will come up. This is a good tight knee. So like a bucket handle, the meniscus flicks into the knee, gets trapped in the knee, and the knee can't extend fully because there's a chunk of meniscus in the notch of the knee. And that's called a locked knee. Locked knee is normally caused by a bucket handle tear, occasionally caused by the ACL, which is ripped and sits forward in the knee, a thump of the ACL stopping extension. So that's a locked knee, and that's relatively urgent. And if it's definitely in a young person, you'd want to reduce that bucket handle and repair it, not remove it. That's what people are used to do. That's a very bad thing to do. And if a surgeon can't repair it, they should reduce it and leave it for someone else to repair at a later date. Lock the knee in extension with the knee reduced, the meniscus reduced, and give it a chance. What we do know about meniscal repair is the lateral meniscus is very important. So even if a 60-year-old in a relatively good knee had a bucket handle tear of the lateral meniscus, I would consider repairing it. Because if you remove the lateral meniscus, patients can get symptomatic OA within 5 to 10 years. If you remove the lateral meniscus in a 10-year-old because he's had a bucket handle tear, he will be developing symptomatic OA before he's 20. So lateral meniscus is important. We know if you lose the medial meniscus, we see patients now who are in the 50s and 60s who had their meniscectomy 20 years ago, they're okay to get arthritis. We know it causes arthritis, but in a slower, more prolonged fashion. So repairing the lateral meniscus, repairing traumatic tears, even the medial meniscus or any meniscal tear, if it's got a blood supply. There's no point repairing a meniscus without a blood supply.
So if you excuse me, that's probably quite important to talk about, if I may, the anatomy of the meniscus and which areas of the meniscus do have a better blood supply.
So the meniscus blood supply comes from the outside, okay? So if you look at the top of the meniscus here, and the meniscus comes from the outside, the inner part of the meniscus, the bit that's commonly torn, a little bit, I think you can see this meniscus has got a flap of tissue here. This meniscus is in a non-blood supply area. Okay, so that's going to involve removing that flap of tissue, as opposed to a meniscus at the tear in the rim. And you can imagine if there's a tear around the rim and that flicks in and out of the knee, a bucket handle tear or a potential bucket handle tear, more likely to have a blood supply, more likely to be sutured back. And if you didn't suture it back, it would involve a substantial meniscectomy. So if it's anything a large meniscectomy, well, why didn't we repair it would be the question. So the blood supply comes from the outside.
Super. One thing that's important that you mentioned earlier is those degenerative meniscal tears. Tell us a bit about that.
So the degenerative meniscal tears we know do well with non-operative treatment unless there's a target meniscal lesion. I'll talk about those in a minute. So if someone's not had a trauma, a degenerative meniscal tear, remember, think grey hair, think cuff tear, think meniscal tear, it's normal, okay? One of my colleagues does a picture that if you're likely to need these, you're more likely to have a tear, one of these, or one of these. Comes with age, degenerative meniscal tears, it's almost a normal variant. It can be aggravated, there can be some minor trauma. Oh yeah, I was playing vets rugby, I was fine, but a couple of days after, they've got a degenerative meniscal tear. And they are typically cleavage, horizontal tears. Okay, we might be able to show a picture. And they'll always treat them non-operatively first. And non-operatively, it's a good 3 months of rehab, I think, from the point of the trigger for pain. There are target meniscal lesions that, again, never say never. All degenerative meniscal tears do not need surgery. That's not true. So there are target meniscal lesions where there's a flap of meniscus. There's a flap of meniscus where it can get trapped between the meniscus and the medial collateral ligament, we call it the inferior synovial recess here, the tear. We have to unflick the tear and remove it, and that's really, really rewarding for the patient. It's like standing on a nail and you've removed the nail. so that can be beneficial in even an elderly patient. A target meniscal lesion, bucket handle tear, a flap tear of the meniscus, or one of these that's trapped, and untrapping and removing that is a partial meniscectomy. You remove the minimum, but for degenerative tear, you can always treat them non-operatively first. And non-operative means quality rehabilitation with a good physiotherapist and a good patient to do those exercises. Occasionally an injection to again buy them some time to do the exercises. And if things then improve, you can do a short, small, quick keyhole procedure for a target lesion. Not for a non-target lesion, but for a target lesion.
Super.
Often those can be associated with locking, catching, giving way,
Sure.
Mechanical pathology. But again, you can treat them non-operatively first. So we talk about traumatic and degenerative meniscal tears and which ones need surgery. So I want you to think about two different types of shoe. One is an old pair of trainers you do your DIY in, or your Sunday trainers, or your slippers. They've got a few holes in them, okay, but they're wearable, but the leather's coming off and you can put your finger through and there's a hole in there. Degenerate tears of a meniscus. Compare that with a new pair of shoes that you wear out on an evening and you trip up and the heel comes off. That shoe you're taking to the cobblers the next day to get the heel put back on. Repairing the meniscus. Trauma, clear injury, fix, degenerate. If it has another rip in it, doesn't matter. Very occasionally, that pair of trainers will have a tear that is so flapping and irritating the inside of the foot that a pair of scissors is going to remove that little bit of flap. Okay, that's a target meniscal lesion in a degenerate knee. So think of old trainers with holes in them, you've got time. Brand new shoes or a good pair of shoes where you've just cut or you've knocked the heel off, you want to think about repairing them.
Now, one thing that you and I have discussed that might be useful to talk about on camera is we've talked about meniscectomies, try and stay away from them to try and preserve the meniscus, we've talked about meniscal repairs, but one of the other things that's coming into fashion is a meniscal transplant. Okay. Would you mind talking us a little bit about that?
Okay, so meniscal transplants are a good procedure with 20-year results of good survival of the graft, the new meniscus. So we take a donor, a dead person's meniscus, an allograft, autograft, you take some of your own hamstrings and put them into the ACL using an autograft or patella tendon for an ACL, an allograft for meniscus from a dead person. It's all cleaned and irradiated and checked and sized to make sure it fits the top of the tibia, not too big, not too small, just right. And we remove the remnant of the meniscus that's behind and we can put in a new meniscus using these modern meniscal repair techniques. Okay, so who would be a candidate for meniscal transplant? Someone who's had a complete meniscectomy, medial or lateral, more often lateral because the knee doesn't tolerate the lateral meniscus going, more often the younger patient, and more often patients who haven't developed frank arthritis. But again, they need a stable knee, either ligaments are intact. They need not too much in terms of arthritis, and they need to understand it's more of a salvage procedure. It's not a procedure we would do in an elite athlete who's going back to sport. It's someone to enable them to do the activities of daily living without pain.
Super. No, brilliant. And I'm sure we'll see more and more about meniscal transplants in the future. So one of the most common ligamental injuries, and I know we've talked about it a lot, is your ACL tears. So I was wondering if we could talk a little bit about rationale for whether someone like yourself might choose, yes, we're going to operate on this ACL, or we're not going to. And one thing I should start off by saying is that we'll talk about this very globally because every patient's different, and we know that there's a lot of controversy out there about should we do conservative, should we do surgical. Yes, they're going to get osteoarthritis later if you don't operate. No, they're not going to get osteoarthritis. So there's a lot of specifics, but perhaps if we might be able to chat about it very globally.
Yeah. So what we do know is an ACL rupture does not cause arthritis. What we do know is an ACL rupture with ongoing instability leads to irreparable meniscal tears, which leads to meniscectomies, which leads to arthritis. So we can link that as night follows day with ongoing instability.
Super.
Okay. So the key is finding those ACL ruptures who haven't got any other pathology, okay, who have one episode of instability and don't have any other risk factors, hyperlaxity, hyperextension, high tibial slope, bilateral, family history, whatever, high pivoting sports. And we call them copers. And that's building up that conversation with the patient and the physiotherapist. Is this patient a coper? Let's go down the non-operative route. So more patients are more likely to go down the non-operative route than others. A 19-year-old gymnast with hyperlaxity, with a high tibial slope, with recavatum, hyperextension, who's got dynamic valgus, is more likely to go down the surgical route than a 45-year-old surgeon who does a little bit of sport occasionally. It's all cycling and straight line activity, no pivoting, who's had an index ACL rupture with one episode of instability. One, off you go, let's see how you go. ACL brace, I use a CTI ACL, which is a very good brace, but any good ACL brace, and physiotherapy, rehab, and let's see. What you don't want to do is treat that 20-year-old or 19-year-old with all the risk factors for ACL, isolated ACL, and a month later she comes in with a big lateral meniscal tear. We've kind of missed the boat. Okay, so you've got to weigh up who gets what. So it's in vogue now to, I've got a meniscal tear. I lecture to a lot of physios, as you know, and I'll say, right, so this is a big meniscal tear. And we've got 100 physios in the room with varying ages from 23 to 70. Who's having an operation? Pretty much no hands go up. I go, it's a bucket handle tear. Then a lot of hands go up. What about this first tear in a lateral meniscus? No, some hands go up, yeah? Or more hands will go up. And then I'll go, okay, this meniscal tear that none of you want surgery for, it's your child's meniscus. Who's having surgery? All the hands go up. So what, none of you, you don't even know how old the child is, but people have very biased opinions. Yeah, your 15-year-old, yes, repair the meniscus. Whereas your 25-year-old physio saying, maybe not. Why? What's the difference? I see you as the same. You're 25, you've got another 70 years of life ahead of you. You're young, fit, sporty physiotherapists. Don't believe all the hype. Nothing's black and white. And in orthopaedics and in MSK, I think sticking to the mantra traumatic, refer early, think refer early, versus degenerative, refer late, or treat, you've got time. I think that's a good approach to have in the back of your mind. So, for the isolate, so who's more likely to get surgery? People with concurrent injuries, where I'm going to repair the meniscus. Not remove it, repair it, number one. Number two, multi-ligaments. Number three, big pivoting sports. Mm-hmm. Footballers, rugby players, hockey players, netballers. It's case report stuff where we've got professional athletes back to sport with ACL ruptures. Mm-hmm. People get so happy about it, they write a case report, it gets published because it's rare. Yeah? Oh, look what I've done, I've got this man back to sport. Okay. People with a high tibial slope on the tibia, you can look this up on the internet. If you have a high tibial slope, it makes you more amenable to ACL rupture, ACL instability, because the natural congruency of the tib-femoral joint doesn't lend itself well to stability. So let me just put that into perspective. High tibial slope means more ACL instability. The reverse, more PCL instability. Sure. So we look at the slope. A-level knee stuff, it doesn't matter, but it helps me decide whether whether the patient's going to have a surgery or not, and also whether I'm going to do extra things like a lateral tenodesis, an extra bit because they're so high risk. Okay, so then as you get the younger patient who's going to do pivoting sports, as you get older into the middle age bracket, so you and I, we've torn our ACL. Okay, I know you're younger than me, Kai, but the questions are going to be the same. How many hours of pivoting sports do you do a week?
0.
Okay, so 0 pivoting sports. You've had 1 episode of instability. You've got nothing else in terms of big meniscal tears or no other associated injuries. You and I would be prime candidates. Okay, I have children. I get on the trampoline with my children still. I still want to play football and hockey and stuff. I still want to ski with my children. I might think more surgical.
Yeah.
Okay, but then it might be just me thinking I'm younger than I am and wanting to go back to, oh yeah, I'm still sporty, but really, am I? And that's where you as physios and me as surgeons and the patient needs to have a grown-up decision on whether we're going to go for surgery or not, because the rehab's extensive.
Sure.
So index rupture, you've got an index isolated rupture of the ACL, pretty good biomechanics, no associated injuries, not a pivoting sports person. You know, we have these rare injuries, people jumped off their sofa playing Xbox, tripped, tore their ACL. They're never going to need an ACL reconstruction. So horses for courses, work it out. And then for everyone that we do go down surgery, repair their meniscus, check their alignment. Do they need something extra, like a lateral tenodesis or an anterior lateral ligament because they're higher risk of re-rupture? All these things. Do they use a patella tendon graft or a quads tendon graft or a hamstring graft? A sprinter's less likely to have a hamstring graft. A prop forward's less likely to have a patella tendon graft. A jumper, basketballer, is less likely to have a patella tendon graft or a quads tendon graft. So you've got to work out these options.
Actually, that's you're probably aware I was going to come on to it. The age-old discussion, patella tendon graft versus hamstring graft. What kind of things help you make a decision around which one you choose?
Well, I think most modern day knee surgeons should be capable of doing all the grafts. Mm-hmm. So in the old days, it'd be whatever the surgeon was good at.
Okay.
Hamstring still by far the commonest. Patella tendons probably definitely more stronger. Mm-hmm. With probably less of a re-rupture rate, but it's not been proven in 40 years, so I'm not sure that answer is going to be solved. I think the quads tendons are newer graft, and time will tell. There's studies going on now. The Stability 2 trial will compare those. Okay. But yeah, so I will use all 3. Okay. Hamstring, patella tendon, quads tendon, and an allograft in certain patients. The older patient, I'll consider using an allograft. Not in the younger patient, because the graft re-rupture rates are unacceptable.
Sure.
And I'll stand by that in front of anyone. An allograft in a 20-year-old is not a good decision.
If I may perhaps ask some possibles that I may have heard of in the past, and perhaps we can discuss those. So I might have heard of, well, is your patient going to do a lot of kneeling? Are they a carpenter? Are they a plumber? As a result, would they be less favourable for a patella tendon graft because they're going to be spending a lot of time on their knees?
Yeah, so those kind of things are important.
Yeah.
So yeah, you can weigh that up. There's a bigger scar.
Sure, yeah.
So your 30-year-old who skis every year who wants a surgery might go for a hamstring because the scars are smaller. Okay. You know, I can harvest hamstring through the size of a fingernail. You know, it's quite small, neat surgery. Patella tendon's quite invasive, and you've got to kneel on the scar. But there are techniques we use now to try and preserve that. But yeah, it's more strength work. Considering most of these people are sports people, you know, they just want the strongest, least likely to recur. Patella tendon is a good option, and as is quads tendon.
If I may, that was probably the second one I was going to ask you. The other stigma, I suppose, if I may call it, is that I've often been told that in elite athletes, a hamstring graft is more flexible and therefore will allow them to do more twisting and turning, whereas does the patella tendon graft, as you said, it's a lot stronger, so therefore is it a little bit more resistive to allow them to be totally flexible, or is that an old wives' tale?
Yeah, I think probably now it's probably more the latter. Okay. But hamstring problems post ACL is a real issue.
Yeah, sure.
So you know, if you're a high-level athlete and you have hamstring issues, then that can be a problem.
Sure.
So it's all shared decision making now, so you can inform the patient, let them make their decision with you. You can offer what you think is good and what you would have, or what what your advice is. But yeah, share that with the patient and explain why you want to use those grafts. And yeah, I think that's important. The other people you want to think about in terms of who gets surgery. So we've talked about people with the risk factors and associated injuries and the high level pivoting sports. But you want to think about also occupations. There's certain occupations that I would consider ACL reconstruction in the non-sporty. Okay. Firemen who need stability, people who work on roofs, roofers. I did a 55-year-old roofer who needs stability, not just for him, for his colleagues who work with him on the roof also need him to be stable if he's above them in a ladder, etc. So it's not always black and white. Policemen who have to do beep tests to get round and pass their annual assessment and their knees not stable. From that to the elite level boxer who needs stability. If you pin an elite level boxer in the middle of the ring, they're okay. They've got a good stable base. You pin them on the rope and start hitting them, they can't escape. They haven't got the stability for it. So it's horses for courses. So not everything's black and white.
That what a superb way to round off. And I think that probably applies to the discussion that we maybe had at the beginning of this ACL segment. It causes OA, it doesn't cause OA. Like you said, every situation is different. Have they had a concurrent injury? Do they have instability? It's not a black and white thing, as I think we seem to portray in the media and social media, that it's very definitive. They do or they don't. As you said, it's very much dependent on each individual.
So when I do this polls with the physios, how many of you've got an isolated ACL rupture, would have surgery? Not many hands go up. So there's a strong belief that they can manage without surgery. How many hands go up when I say you've got an ACL and a lateral meniscus? A lot more hands go up. And the devil's in the detail, because by the time you've had that lateral meniscus, I told you the progression is ACL, ongoing instability, irreparable meniscal tears, OA. Okay, so the risk of chondral, articular surface, and meniscal injury after ACL in an unstable knee is 1% a month.
Wow, right.
The key is unstable knee.
Yeah.
So when the patient you're treating non-operatively says my knee's giving way still, get it referred. Don't wait.
So guys, I really hope you've enjoyed this video. And if you have, we'd be super grateful for your support in smashing that like button. And we've got loads more from Mr Trikha as well on our YouTube channel, including the subjective assessment, the objective assessment, and more clinical reasoning videos for the knee. We also have links in the description below for our social media channels, as well as our website, clinicalphysio.com, where we've got even more fantastic content for you. My name's Khalid Maidan. Thank you so much for watching, and we'll see you really soon right here on Clinical Physio.